Hello and welcome to our colon cancer awareness, understanding, preventing, and managing colon cancer forum. My name is Delilah Sochi, and I am the Community Health Manager at Garnet Health, and I will be your moderator. I will be introducing two esteemed medical experts who will be sharing valuable insight on this topic. Join me in welcoming Dr. Lance Siegel, Dr. Sean. Dr. Lance Siegel is a board-certified gastroenterologist in Goshen, New York, with extensive experience in esophageal disorders, pancreatic disease, and gastrointestinal disorders. He graduated from Albert Einstein College of Medicine and completed his residency at New York Presbyterian Hospital, Columbia Presbyterian Center. He is affiliated with medical facilities, St. Anthony's Community Hospital, and Garnet Health. A fun fact about Dr. Siegel is he is fluent in Spanish and is an avid film enthusiast. We have Dr. Sean, who also specializes in gastroenterology and adult gastroenterology and is board certified in internal medicine and gastroenterology. She is fluent in English, Korean, and Spanish. Dr. Chong earned her medical degree from New York University School of Medicine and completed her residency, internship, and fellowship at NYU Medical Center. She is affiliated with Garnet Health Medical Center and St. Anthony Community Hospital. Joining the profession in 2002, her clinical interests include colon cancer screening, inflammatory bowel disease, reflux, celiac disease, gallbladder disease, and hepatitis. So let's start with what is colon cancer. Colon cancer is when a benign pancreas growth in the colon transforms into cancer. It's the third most common cancer worldwide and second leading cause of cancer-related deaths. The good news is it's often preventable with early detection and lifestyle changes. How does colon cancer develop? Colon cancer usually develops from polyps, and polyps are small growths in the lining of the colon. The transportation from polyp to cancer can typically take around 10 years, which is why regular screening is so important for early detection and prevention. Some of the factors that can increase your risk include age. So risk increases with age, especially after 50. Family history. A family history of colon cancer or polyps raises your risk. Metabolic issues like obesity and type 2 diabetes can contribute as well. Tobacco and alcohol use is known for risk factors, and certain health conditions like inflammatory bowel disease, colitis, or Crohn's, or blood disorders may also raise the risk. Environmental exposures like radiation or toxins may also play a role. I will now turn it over to Dr. Siegel and Dr. Chung, who will discuss how colon cancer is diagnosed, when screening should begin, the available treatment options, and we'll also take questions from the audience. Thank you for joining.
Okay.
Next slide.
Okay. So how can it be diagnosed? So there's a number of different ways that it can be diagnosed, but if we had to choose one, Dr. Chung, what would it be?
Get your screening colonoscopy.
100%. So there are many different ways that are FDA approved, but FDA approved screening tests doesn't necessarily mean that they're the best screening test. And one of the important things with this to think about is a diagnostic test versus a therapeutic test. So out of all the things that are listed there on the slides, the one test that's really comprehensive and therapeutic is the colonoscopy. So most people know what a colonoscopy is. Basically, putting a scope up from the rectum all the way around the colon. Colon's about 5 feet long. It should only be done by somebody who does these very frequently. It's not always easy to get all the way around the colon, so you want somebody who's well trained and does a lot of colonoscopies, period. And again, they're both diagnostic and therapeutic. Most people do colonoscopies under sedation. Very rarely, some people don't want to be sedated, and that's fine. But the colonoscopy is somewhat uncomfortable if you're awake, because it feels, for people who know what a gas cramp feels like, you feel like a spasm. That's kind of what a colonoscopy feels like when you're awake. The beauty of finding the colonoscopy polyps and then removing them, you don't really feel them if you're awake, whether you're awake or asleep, because there are no nerve endings on the inner wall of the bowel where you would have to worry about whether we cut them off or burn them off. You wouldn't feel that. And again, we also find early cancers that we can remove. The trick with the colonoscopy is you have to have a good preparation. So everybody knows about colonoscopy preparations. You have to be on liquids for a day, and then you either drink a prep or you take 24 pills and you stay up most of the night. And it's like getting food poisoning. The joke is, instead of doing the colonoscopy prep, you just eat a lot of fast food and you get the same effect, but I'm not going to mention
It's a necessary evil, though.
it is a necessary evil, and hopefully it only needs to be done every 5 or 10 years. And as I said, the frequency of how often to get a colonoscopy really depends on the family history, what your risks are. You
And how
can't
many polyps you find that are of a particular type of polyp?
100%. And the other potential downside, although it's rare, the risk of complications from a colonoscopy really much less than 1 in 1,000. Bleeding when you take out polyps. People worry about the risk for perforation with colonoscopy. The risk is not zero, but with newer colonoscopy techniques, endoclips, things that we do to try and prevent perforations, the risk is minimal. It's not zero, but it's become much less than it was when we were training many years ago. Not me, many more years ago than you. So the next test is the one that you see on TV all the time, the talking box, the dreaded Cologuard. That's not dreaded, but it's better than nothing. This is what I tell my patients about Cologuard. It's very easy. It's done at home. It's only done by prescription. You collect the stool in a container. The container actually mounts
On the box.
in the toilet, and then you close it up and you put it back in the box and you mail it off to the lab. They're checking for blood in the stool, and they're also checking for abnormal DNA. It is fairly accurate. It finds 92% of colon cancers, which means it misses 8% of colon cancers. My pet peeve about the Cologuard is that it misses a much higher percentage of colon polyps. And again, it's not preventative from the standpoint of it misses a lot of polyps. So my concern is a false negative Cologuard. Somebody can still develop colon cancer in a shorter interval if it missed that polyp. The recommendations are get it done every few years.
It's every 3 years, but really, if there's any symptoms, if you're iron deficient, if you're having problems, it's not a screening test. It's not a good test to do.
Yes, that's actually a very good point, because it's not FDA approved for high risk patients.
That includes family history.
Absolutely.
And because we've had several people come through with symptoms and people are ordering them as a screening. A screening means you have nothing. You don't feel anything, you're not anemic, your labs are perfect.
Yeah.
So it's a big difference. Yeah.
And then like I said, next time you watch the commercial, look at the bottom of the screen. It says not for people at high risk.
Right.
And the other thing, there's a very high false positive rate. So we both had people in our office who are sure they have colon cancer. And then the majority of time, the large majority of time, when you have a positive Cologuard, you don't have colon cancer. You either have polyps or you have nothing. So it's
We may frequently find precancerous polyps, though. So if you have a positive Cologuard, then you have to do another test, which is the colonoscopy.
Yes.
So we're back to the colonoscopy.
And we're back to the colonoscopy. And then the colonoscopy is and then you have to prep for the colonoscopy. So now there's 2 tests. So there's also issues regarding the cost.
Which makes it it's not a preventative if you have a positive Cologuard.
That's right.
You have a diagnostic colonoscopy, and that may change depending on your insurance.
That's right, because coverage, that's exactly right, because coverage as a preventative, the insurance companies have to cover preventative, but some of the insurance companies say they don't cover diagnostic, only preventative, and then all of a sudden, that's right, some of those costs get pushed onto the patient. So those are things to also consider. The stool blood test, the FIT test, and the fecal occult blood test, old tests, they're very good. They're not as sensitive as the colonoscopy or even the Cologuard for colon cancer, but they're useful, especially for people who are a little gun shy about doing anything, these are non-invasive, they're done at home, they're low cost, they're easy, there's no special diet for the fit, although for the fecal occult blood test, FOBT, you have to avoid red meat and certain vitamins, yeah, because it'll trigger a false positive. And again, if those are positive, then you go right to the colonoscopy. And those tests can be done every year. They're very cheap and inexpensive, and really no invasive prepping. CT colonography or the virtual colonoscopy, that was very hot in the media for a very short period of time until people really heard what it was about. You know, people thought they just hop on the table for the CAT scanner and it would recreate a virtual colonoscopy, when in fact you have to do the same prep that you do for the colonoscopy. They stick a tube into your rectum when you're wide awake. They blow air into your colon to stretch it open so that they can actually try to see if there are any polyps in there. It can be quite uncomfortable, and there's a risk for perforation. So I don't really use the CT colonography that much, only for people who can't have a colonoscopy, and I think the Cologuard's probably supplanted that as well.
There's another instance would maybe be if you can't get through with a regular colonoscopy for some reason, and you want to see the other side of the colon.
Yes,
It can be useful.
yes, stricture, strip,
Yeah,
right?
yeah.
Absolutely. Now, the sigmoidoscopy, which is what we used to do about 30 years ago, before Congress passed the law saying that colonoscopy screening was important. And really, like I said, that came about in part because of Ronald Reagan and Tip O'Neill, and then efforts by the cancer societies. So the sigmoidoscopy looks at the left side of the colon. It's done with you wide awake. It can be combined with those stool tests, the FIT test, or the fecal occult blood test. It's better than nothing. It's certainly not nearly as good as the colonoscopy, but again, it is better than nothing, and it's done without sedation as well. And then there's the new blood test, Shield, I think is the name of the Shield test. It's FDA approved. We don't recommend it. The miss rate for colon cancers is higher than the Cologuard. And if you combine the cost of the test with the cost of then having to do the colonoscopy and the false negatives and the false positives, it's actually not cost effective. And this is really just FDA approved, a number of months
A few
ago.
months ago.
Yeah, but it's out there. Listen, the bottom line is the key is get screened. So anything is better than nothing when it comes to screening, with the caveats we mentioned above: the slight risk of the procedure of colonoscopy, the stress related to false positive Cologuards,
The bottom line is, if you're healthy enough to be able to do a prep and sustain the anesthesia, which affects your blood pressure, breathing and heart rate. We call that IV anesthesia, total IV anesthesia, but it's really propofol, which was the Michael Jackson drug. But somebody's monitoring this the whole time.
That's right. That was
Anesthesiologist is monitoring the vitals the whole time.
yes.
Then the sensitivity of colonoscopy is 99% plus with a good prep.
Exactly. So that's always the key with colonoscopy. You have to get a good prep. But yes, all of these, everything that I mentioned here is real, that we mentioned here, excuse me, is really just so that you have a complete picture of what is approved as screening tests. But nothing comes close to the colonoscopy as far as diagnostic and therapeutic, one-shot deal, being done, very safe. Anesthesiologist is monitoring you while we're monitoring the colon. So nothing beats colonoscopy. And again, if everything is fine and there's no family history, no symptoms, generally it's 10 years before the next colonoscopy. And if we find polyps, then we'll talk about that a little bit later. But again, these colonoscopy saves lives. This is the bottom line. There's a few screening things that saves lives and decreases the incidence of decreases mortality from colon cancer, and colonoscopy is the one.
Okay, next slide.
Excuse me. Okay. Do you want to start this one, or do you want me to start this one?
Do you need a break?
Yeah, no, I'm doing great. We're on a roll. Are you kidding?
All right,
No, go ahead.
I'll fill in.
So age to start, just jump in anytime. Screening again, it used to be age 50, but with the increasing incidence or prevalence of colon cancer in people under the age of 50, they dropped it down to 45. But the key with that is really knowing your family history. Because the real age to start really depends on your risk factors. And again, as an example, if you have a first degree relative that had colon cancer at age 40, then you're not going to start at 45. You're going to start 10 years earlier than the youngest person in your family. So for that example, you would start your colonoscopies at age 30. If
And
you,
that's not just colon cancer, but actually precancerous polyps
an
are
excellent
on
point.
that same vein.
An excellent point. We used to talk about, family history of colon cancer. Now we're really hoping to just talk about family history of colon polyps. Excellent point. All right, so again, when we talk about, genetic conditions, other risk factors. So the screening that we talked about, stool-based tests. And again, the stool-based tests should be done every year. And the timing of follow-up colonoscopies really depends on what you find with the initial colonoscopy. As an example, if you have 10 precancerous polyps, you're going to get checked within 6 to 12 months. If you have 1 or 2 polyps that are small, you might get checked 5 to 7 years. If you have 3 or more polyps that are of a certain size, you might get checked in 3 years. So whether you get checked in 6 to 12 months, 3 years, 5 years, 7 years, or 10 years, totally depends on what we find with the colonoscopy. And again, your other risk factors.
Next slide.
Okay, so then, so when do you stop screening? So I have people you probably have these also. I have people in my office at 70, 80, 85, 88 years old demanding their colonoscopies because they're not going to let anybody tell them that they can't have their follow-up
Well,
screening.
people live to about 105 now.
That's
I
right.
know Many.
Yeah, so really the question is, when do you stop screening? Now, a lot of so we talked about when you start. So really they say up to 75, and then you look at the individual. So a lot of patients will come into my office and they'll say, and they're 76 and they haven't had a colonoscopy in 10 years. And they'll say, I'm 76, I don't need a colonoscopy anymore. And I'm like, no, you haven't had one in 10 years. If you're going to stop at 75, as an example, you actually have to have a colonoscopy at 75 that shows that you don't have any polyps. Then you could consider stopping.
It just depends on where they are, how frail, what the other comorbidities are. Like if there's heart failure or you can't breathe from emphysema, maybe that person might get a screening Cologuard at that point, especially if it's been 10 years and they didn't find anything at 65.
Yeah.
But if they're playing pickleball and running around playing golf and things like that, and they're very active and they don't think the prep is a big deal.
Yeah.
I mean, I've done them up to age 85 as a screening.
Yeah.
Because people at that point, people vary in how,
Yes.
rigorous they are.
Yes, and again, a lot of people in their 70s, 80s don't like being told that they can't have
That's right.
they can't have their screening anymore. I always say, pickleball is a good example. I say if I have an 82-year-old who's going to climb Mount Kilimanjaro, they're getting a colonoscopy before they go on their climbing trip. But exactly right. If you have a 77-year-old who has congestive heart failure or bad emphysema, then you really don't want to put them under sedation because the risks of the procedure are higher. And I agree. Then you would do something less invasive like a Cologuard. And if that ends up being positive, then you would
Risk it in the
consider
hospital.
in a hospital setting. But again, the trick is really looking at the specifics. But they also always talk about the risks of the bowel wall thinning and the perforation risk. It's not
nothing.
It's not nothing, but it's not as dramatic an increased risk as people say.
And I think there's a reason why, just the same reason that adenoma detection rates have gone up, which means the ability to find precancerous polyps in the colon have gone up in the years. We have high def monitoring with, the technology to view much wider range of the camera view. So it used to be maybe 270-degree view, but now it's almost like 340 degrees or so where we can really see. So it has become clearer. So the ability to maneuver through the colon without really just pushing, and doing it blindly has greatly changed the safety profile, I think, of
Absolutely.
colonoscopy.
Absolutely. And then the newer techniques. We use these endo clips when we take off polyps. We used to burn off polyps and keep our fingers crossed. Now we burn off polyps, and depending on where in the colon they are, how much cautery we use, we'll use clips or claws, all sorts of things to close the bowel wall so that it doesn't, not close that it's open, but prevent it from
And
perforating.
you can imagine like endo clip is like a staple almost. So what we're doing is just kind of stapling things closed that we didn't have that capacity to do before.
Yeah.
Which has really also decreased perforation and bleeding risks.
Yeah.
In colonoscopy that you've heard in the past.
Definitely a game changer. Okay. All right.
Okay.
What else we have? What else?
All right, so,
More.
next slide.
Yes.
Are we there already?
Yes.
Oh, wow, okay. I feel like,
What about
Oh.
prevention?
Let's see. Oh, I guess the slide is in here. This is, I don't know if this slide should be right here, but if we are talking about having the diagnosis, yeah, let's go back to that maybe later. What symptoms would you have if you had colon cancer or colon polyps? And in the beginning, especially early stage where Dr. Siegel had said it's almost, definitely over 90%, stage 1, stage 2. Stage 0 is 95% survival rate at 5 years. You might not have any symptoms at all.
Absolutely.
And so just because you don't feel anything doesn't mean it's not there, right? And that's what we can do with the camera to be able to visualize and say if there's something there or if it's not. And not only say, but also then remove most typical polyps. Some of the very large ones have to be set up a different way, either by surgery or some advanced techniques of removal of polyps.
The key is exactly what you're saying, that people, if you wait for symptoms, it's not too late for necessarily for a cure, but it's oftentimes too late
There.
for something's already there, and it might be too late for an easy cure. Because stage 1, stage 2, usually those people just get a surgical resection and that's it. No postoperative chemotherapy. But the more advanced stages 3 and 4, patients will have to go through other modalities to help prevent recurrence. As far as rectal bleeding goes, people, especially again, about when people have rectal cancer specifically, those polyps and cancers may bleed, and people just assume, oh, it's my hemorrhoids. So I literally had one of those today. The patient had not been screened before. She was in her mid-60s, and unfortunately, had a little bit of bleeding, and again had not been checked at an earlier age, and she has a lesion in her rectum. But that's why it's important to get checked when there are no symptoms, based on your age and risk factors, or if any of these symptoms on the slides, change of bowels, again, unexplained weight loss. I always tease people when they say I've gained weight. I say that's okay. We don't want to gain too much, but we worry more about unexplained weight loss unless you have congestive heart failure or cirrhosis. But we're not going to talk about those today.
But one of the other things I think commonly what prevent people or patients to come and get a colonoscopy is like, well, why didn't you go? It was the fear of knowing, right? Or finding out they have colon cancer. But I think the emphasis here is going to be, even if you have it, because it's so treatable, especially early, find out about it. Don't fear the unknown and just get it done. All right.
Absolutely, 100%.
Okay. Well, next slide. Okay, so what can I do to prevent colon cancer? Because, people are at the colonoscopy, they find out they have polyp. What could I have done? I've done everything right. Well, the message for today is 45. It's not 50 anymore. So remember the number 40. Start at 45. Eat healthy. Every day is a process. So you eat healthy. And I put the word in adequate fiber because there's actually such a thing as too much fiber, which will just bloat, gas you, and make you constipated. So moderate amount of fiber, because no fiber doesn't work either, but you got to get some in there. Stay active, but that doesn't mean go do a 20-mile run. You have to find your limitations, because as we get older, our body's not the same, and you just wanna get your physicality up, but don't, if you do too much too soon, then now your joints ache and now you're not gonna do anything at all. So you have to find that balance too. So hydrate. And what is hydration? We say half your body weight in ounces is one,
That's right.
one parameter, so if you're 180 pounds, then half of that is 90 ounces. That's still a lot, but well, I always say try to drink one more cup than usual of water, because that is our body is 2/3 water.
Yes, carry it with you. Carry it with you. Get a refillable.
Yeah.
As my kids have told me, get a refillable bottle,
Mhm.
less plastic.
Red meat intake. Typically, red meat is one of those things that and that's why is the colon cancer higher, the incidence of colon cancer higher here in the United States than elsewhere? Red meat has something to do with it. Fatty foods, the processed foods, the way the factories make foods. So try to stick to the periphery of the grocery store and get your whole foods, right? And alcohol, too much alcohol can definitely increase your risk for polyps. Cirrhotics have a lot of polyps. And of course, smoking it's not just colon cancer, but a lot of other cancers too.
Yeah.
So avoid that at all costs. And it's also a vasoconstrictor to the heart,
That's right.
right? Or the blood vessels.
I like that. State of the
Periphery
of the grocery store. I like that. And the fiber thing is actually very good. Like, yeah, good healthy diet. People are like, oh, because a lot of times people come to the office with bloating and gassiness, and it's because they're being too aggressive with their fiber. That's the definition of fiber.
Right.
We're not digesting it.
So sometimes I even give a number, which, greater than 40 is too much fiber, grams of fiber. So you want to probably stick to definitely less than that, but maybe closer to 25 to 30 or so, especially when you're getting gassy and bloated.
Yeah.
Yeah.
The last thing I always tell people is if you think it's bad for you, it probably is. Don't try to convince yourself that these processed foods or these ultra processed foods, aren't bad for you. Twinkies are bad. I'm sorry if anybody works for Hostess.
Okay, next slide.
All right.
Treatment.
Treatment, sure. So treatment, again, getting back to that issue of colon cancer versus rectal cancer. So when people have cancer in the colon above the zone of the rectum, usually those people are going to go straight for surgery. So if we diagnose somebody with colon cancer and it cannot be removed with the scope, because again, even early colon cancers sometimes can be removed with the colonoscope by a advanced endoscopist. Those patients, if they're a good surgical candidate, they'll go right for surgery to remove the tumor. And usually it does not involve a colostomy bag. Usually there's what's called a primary anastomosis, where it's like splicing a tape for us old people, right? You cut the tape, you splice it together. It's the same thing with the colon. I don't know if the surgeons will say that it's that easy, but it sounds easy. And then you check the pathology. So if the colon tumor has not spread beyond the wall, it's not in the lymph nodes, it's not metastatic. Usually people get a CAT scan or a PET scan before the surgery. So if it's within the wall and it hasn't gone into the lymph nodes or gone outside the wall, we consider that to be hopefully a cure. And again, the 5-year survival rate can be upwards 90-95%. If it's gone through the wall, it's in the lymph nodes, then those patients will end up seeing an oncologist, and usually they'll get some form of chemotherapy, and again, also some of these newer immunotherapies can be used as well. The issue of radiation and chemo before surgery is more important for rectal cancer specifically. Oftentimes with rectal cancer, usually in fact, rather than going straight to surgery, they try and shrink the tumors or even melt the tumors away with radiation and chemo specifically to the rectum. And then the decision about timing of surgery will be after that course has been completed. Palliative care is also important because you got to treat the whole person. not just the tumor. So that's an important thing for the entire team. Doctors hopefully don't lose sight of that.
That's right. So now can we go back to slide 10 if you're able to? Not 10. Where was it was at 9, maybe, right? Yeah, what are the emotional and really, when you're diagnosed with colon cancer, you could feel any range of emotions, and you can see the list there. I think often there's shock for the first time you find out, especially if you don't feel
Yeah.
any symptoms when you get diagnosed. But even when you do, it becomes almost surreal, and so it's something that your family support, your friends support, and as providers, we have to be in tune with just, I think, being sensitive around the initial diagnosis, and of course, then getting them to the right appointments, whether it would be with surgery, oncology, or radiation therapy, etc. So, and we want to do that all timely as possible, because as long as it's early, then now you can go to that slide 13. We say, it's very, very treatable. And so instead of becoming angry or just hopeless, what the advice would be is to, get the right steps and do what you have to do to get the treatment and move on and do the best that you can do with the situation you have in front of you, right? But don't panic, which is slide 13.
Okay, where's slide 13?
Someone made a very good slide. I want to give them credit.
Don't
Right.
panic. I love it.
Don't panic, rather seek the care you need, right?
Yes, I mean, I think the you'll move forward. You don't look backwards.
That's right.
We both have this all the time where people, as I was talking about the page today, where people, why didn't I get checked? You can't look back. You look forward, move forward, and hopefully these things, again, it's very treatable. It's the 5-year survival rate is excellent. Even with stage 3 and 4, there's a
It's
good,
about 65 to 75%. So
exactly.
still
You know.
there's very good chance of
And
just getting.
yes, and that's all covered. So I mean, I think the bottom line, hopefully from what we've been talking about, is just get checked. Early detection, early detection saves lives. Polyps don't cause any symptoms. Even early cancers don't necessarily cause any symptoms. So don't wait for symptoms. Get checked early. The colonoscopy is both diagnostic and therapeutic. It is the best screening test. The other ones I feel are really are inferior tests.
And it's very common. Remember, it happened to Ronald Reagan, Ruth Bader Ginsburg, Daryl Strawberry. So it could happen to one of us, right? So
Absolutely.
just get checked. And that's it.
And that's we're glad to take questions.
Thank you guys so much. I believe we do have some questions and a Q&A. And for those of you, if you're interested in
Can't read that. You want to read it out loud for us, Kamara?
I will.
Because I think it's a little
So
bit
here's one
tiny.
here. Can you guys hear me okay, right?
Yes.
Yes.
All right. So here's the question here. If colon cancer spreads to the liver, is surgery still an option?
Yes, but that person is going to need targeted some type of therapy for the liver as well. I've had a number of patients who are 15, 20 years out, they still had the surgery on the colon because you don't want to leave that cancer there, because if it could keep growing and eventually obstruct, then you would need emergent surgery and possibly even, again, a colostomy bag. So you still want to deal with the tumor that's in the bowel, but then depending on what type of lesion is in the liver, how many lesions there are, how large they are, there are different techniques to deal with that as well.
So, something else to consider is that not all surgery is curative. So what Dr. Siegel was saying is that sometimes you'll have to, for obstructive purposes, people need to get the segment out that's blocked. And it may or may not, especially with targeted therapy, maybe there's different therapies, but sometimes surgery is not necessarily for cure.
Yes.
But they could in the right situation.
Absolutely.
Well, then I have another question here. It says, how often should I get colonoscopies after colon cancer treatment?
Ooh, interesting question. So one of the answers to that, which, there are guidelines that you'll check, some of this is we're guided by the oncologist.
That's right.
Some of it really, not hate to say this, patient's peace of mind. All right. So we give people the guidelines and people have to be comfortable with what the guidelines are, but we'll check
The
very,
first year.
the
we
first
definitely
year,
check.
absolutely.
1 year after the diagnosis is definite number one. Yeah.
Yeah. And then
And after that, your oncologist might say 3 years. I think a lot of them come back. Usually you follow along with the oncologist. It would be not more than 5, but the next one could be 3, depending upon, again, on what we find the next time we.
That's right,
do the
exactly.
colonoscopy.
So that's why I was kind of hesitating because it depends on what if we start finding a lot more polyps, like a lot of
At the
polyps.
anastomose where the surgical site was
Yeah.
or anything like that.
Yeah.
So
So
it varies with after the first diagnosis, it's 1 year.
it's within a year.
And then 3 to 5 maybe, but we can't put a firm number
Yeah.
on that. Yeah.
Yeah, the important thing is that you tell people what the guidelines are so that they understand what what the official recommendations are. But we are guided by what the oncologists want.
Mhm. And symptomatically, if there's anemia, if there's issues, again, symptomatic issues the patient has, that it may change to the timing of it.
Yeah, and again, also depends as Dr. Chung was saying, depends on what you find on that next colonoscopy. And also depends on the age of the patient, so there are always variables, but definitely within a year,
First.
the first one.
So the next question I have is, do hemorrhoids have any effect of developing colon cancer?
They're mostly just annoying. But all kidding aside, what I mentioned before, the issue with hemorrhoids really has to do with people assuming that their minor rectal bleeding is related to their hemorrhoids. Because hemorrhoids will bleed red blood. But a polyp or a cancer low down in the rectum or even in the sigmoid colon, which is just above the rectum, may also bleed red blood. So
Right.
people need to take that seriously. And we as gastroenterologists need to take that seriously as well, especially with younger aged people under the age of 45. If somebody, is 38 or 42 and they're having rectal bleeding, yes, you can say, okay, is it just hemorrhoids? You can't assume that anymore. So it's not that hemorrhoids per se increase the risk for colon cancer, but colon cancer and colon polyps can mimic the symptoms of
Each other.
exactly. Thank you.
Thank you. Does having diverticula increase the likelihood of forming polyps, or are they unrelated?
Mostly unrelated. Diverticulosis is extremely common. Everybody, I always tell people, if you live long enough, you get diverticulosis. You don't necessarily get diverticulitis. The majority of people with diverticulosis never get diverticulitis. There are other things that are associated with diverticulosis. Segmental colitis is associated with diverticulosis. Colon cancer per se, I don't see anything off the top of my head regarding.
So we were talking about inflammation
Yes,
before.
that's why I mentioned
So
the
if-
segmental colitis.
If there's ongoing inflammation with any segment, we talked about with ulcerative colitis and Crohn's, it increases your risk for cancer. I think if diverticulosis or diverticulitis occurs frequently, you have to look back and say, oh, it's not just another attack. After a while, you have to go back and do another colonoscopy because sometimes something could be causing that type of inflammation.
Yeah,
right?
actually, a very good point. The the recommendations changed a number of years ago. It used to be that if you've had a colonoscopy within a few years of a diverticulitis episode, you don't have to go get another colonoscopy. Now they're actually saying if it's over a year, you
You
should
should consider.
you should consider repeating the colonoscopy because there may be something else going on. So, and in that setting, if there's ongoing inflammation, Crohn's disease of the colon or colon polyps in that area, that could be triggering the diverticulitis episodes. So again, so in that regard, it can be that there's precancerous or even cancerous tissue in that same area.
Right, so I don't think diverticulitis predisposes to polyps, but it is a trickier area because if you can think of the pockets or potholes as landmines, right? It's harder to see everything on one view when you go in with the like the tunnel view of the colonoscope. So there could be a greater miss rate if the segment, because it is a little more inflamed or becomes chronically inflamed, it becomes what we call hypertrophied or thicker, the muscle becomes thicker. It's harder to actually see unless you go very carefully or, and sometimes you can't because it's just a tighter area. So there might be a higher chance that you might miss something as you're backing off, especially if somebody's moving or anything because there's more air because that's filling up because it's tighter. So it's not that it causes the polyp, but it may, we have to look more carefully at areas that do stay chronically inflamed.
Absolutely, absolutely.
Good information. All right, the next question is there a better type of fiber? So soluble fiber, like benefiber versus insoluble fiber?
The everybody always talks about psyllium husk being the right, but I generally what I tell people is it's what you can tolerate. Some people can tolerate just dietary fiber and they don't need any fiber supplementation. Excuse me. But yeah, some people have trouble with fiber like Metamucil because it is more notorious for giving the bloating and gassiness. So I always tell people if they're going to take fiber supplementation, take it with the food rather than on an empty stomach. You're less likely to get side effects from it with the bloating and the gassiness. So I always encourage people to try and do it in their diet first, and then go to the supplementation afterwards. And some of the fibers, fiber comes in gummy form, it's wafer form. I mean, they've made it so easy to supplement your fiber. The fiber wafers. I like the fiber wafers. The gummies are pretty good. It's easier than mixing up the fiber, but it's really diet. I say diet fiber first, and then really whatever you can tolerate. That's not going to give you side effects.
I would have to agree with that fiber can some of the supplements can make you gassy, so then you're not really gonna wanna take it regularly. But number two, like we talked about before, too much fiber can be a problem.
Yes. Oh,
I think we
100%.
actually shared a patient at St. Anthony, who accidentally suicide ingestion, swallowed a whole container of fiber in one sitting, and he ended up with a small bowel obstruction. So think adequate or moderate fiber, but don't think all the fiber in the world is going to help you because
Yes.
everything in moderation.
Yeah. So I'll have patients sometimes will say, but I eat so much fiber. I'm so good with I'm so good with the fiber. I don't smoke. How come I still have two polyps? So I always say to them, there's no parallel universe. If you didn't do that, maybe you would have had 10 polyps, or you could have had colon cancer. So patients should not get flustered or frustrated if they end up having polyps in the colon, and they've been very good with the diet, and they take a lot of fiber because it could have been worse if they weren't doing those things. And clearly, the data shows that if you're not doing those things, you are more likely to run into problems with polyps and cancer.
And so that is another question people ask. I do everything. So why do I have polyps? And what can I do then? Get your colonoscopy.
Get your colonoscopy.
There's a common theme here.
That's right. There is a common thing. The bottom line is, as good as you are,
Yeah,
it does lower the risk. It doesn't completely prevent it, no matter how good you are.
Yeah.
Yeah, so get your, yeah,
because we
get,
can take out the polyp before it turns into cancer, right when it's on the lining and not when it spreads deeper into the walls. So it's
Yeah.
earlier is better.
and one other data point, the lifetime risk for colon cancer, average is about 1 in 24, 1 in 25 people, 4% of people lifetime risk. But again, that's average risk. That's not even, we're talking about the people who have high risk. So it's not a small number.
All right, and I have another question. Says my family has a history of colon cancer. How soon should I get a screening colonoscopy?
Again, depends on the age at which the youngest person was diagnosed
Of a first degree relative,
of the first degree.
mother, father, sibling, or child,
Yeah.
not aunt or grandpa.
Now, second degree relatives also can increase the risk, but it's not nearly as strong. And if you have two first degree relatives, that's even stronger. If you have a first degree relative and a second degree relative. So it depends on the age of diagnosis of the closest relative.
And then you start 10 years before that. So, so it's 50, then you start at 40. But
So-
if it's 60 or higher, 60, we still say 40,
That's right.
by the way.
So this is an interesting question, and I'm not sure if you guys know about insurance, but the person asked if they're under 45, will the colonoscopy be covered by their insurance? That's a great question.
With or without family history?
So I guess.
With
so
family
it would-
history, absolutely.
Yeah, and
Without,
with, with symptoms, really depends on symptoms.
right.
So if you have a 38-year-old who's having rectal bleeding,
Mhm.
even if they don't have family history, they'll get covered. Iron deficiency, change in
Hmm.
bowels, thinning of the stools, unexplained weight loss, constipation, change in
Abdominal
bowels.
pain,
Yeah.
left lower quadrant pain, there's a lot
Yeah,
of diagnosis. Because, we're not just looking for cancer, there's Crohn's disease.
Mm.
Diverticular disease can cause bleeding
Yeah,
sometimes too.
so excellent point. Ulcerative colitis, Crohn's disease, these are diseases of young people. So if we see a 22-year-old who comes into the office who's having 8 bloody bowel movements a day, their insurance company is covering their colonoscopy. So as long as there's a legitimate indication, the insurances are generally pretty good that way.
But that would be a diagnostic, not a screening, just so you know.
That's good to know. And then another question here says, can certain types of stomach surgery cause an increase in polyps?
Like bariatric or what kind of stomach surgery?
They didn't say, they just left it vague, stomach
Because if it's
surgery.
bariatric, then Dr. Siegel talked about, if your BMI is higher, then that may increase it, or maybe you have some associations like diabetes, which definitely increases your risk. And instead of every 10 years, that's an every 5-year indication for screening. So I don't know if it's the surgery or maybe some of the associated things associated. Right?
Yeah, I mean, there's certain surgeries that end up increasing your risk for colon symptoms. People who have their gallbladder removed, a certain percentage of them can have chronic diarrhea, that might lead to colonoscopies as a diagnostic test. But that's a tricky question because it's very broad.
Yeah. Not necessarily obvious, or it's not necessarily.
Yes.
Yeah, I would say not sure.
Yeah,
But probably
it'd be helpful. Yeah,
we need more information.
yeah, we need more information about the specific type of
Surgery.
that they were having.
Yeah, he confirmed yes, bariatric.
Bariatric. Okay.
So
So in theory, by having a significant weight loss, in theory that helps prevent colon polyps and colon cancers.
but if it's the first time colonoscopy, we don't know if it was already there.
That's right. Exactly. Good point. Very good point. So yeah,
With the risks of were they eating a lot of processed foods and
Yeah.
the fatty stuff before? Or
that's
not?
true.
Yeah.
That's right. That's right. Also
So
has
there's
to do with
their
what,
association.
yeah, so other associates, that's right. So diet, what the diet was like beforehand. That's also a very good point. And then there's some loose, not loose, but subtle associations between calcium intake is good for prevention, vitamin D, aspirin, non-steroidals. Now, we're not telling you to take 10 Advil a day to prevent colon cancer.
We're gonna get our business back.
Yeah, that's right. Then everybody will get endoscopies for ulcers. But there are there are other supplements that actually that
But it's not
But there's-
standard of care.
that's right. There's not official recommendation. Baby aspirin, like you said, it's not official. Those are not official guidelines.
Right.
But there is some loose association that it can decrease your relative risk for colon cancer. But it's really the whole lifestyle.
Right. So it's 8:03 now. Are there more questions? I didn't wanna
That is, so
hold
there's
everybody.
not a question, but someone did say, not a question, just wanted to say what a great webinar, super helpful and easy to follow. Thanks for making all that info way less overwhelming.
You're
And yes,
welcome.
absolutely.
We're happy
You
to
guys did great.
serve the
Thank you so
community.
much.
Yes, glad to do it.
Yes, you guys are awesome. Thank you so much.
It's our pleasure. All right. Have a good night, everybody.
All right, good night.
Thank you.
Good night, everyone. Thanks again.